for asking me to introduce Carlos Morillo, who in my view is a rock star, although his bio says that he's a frustrated musician. I view myself as the warm-up act for him because I've been talking with you about Chagas disease over the years, and now you are going to hear about Chagas disease from someone who knows so much more about it than I do and is actually responsible for some really incredible research in this area. I can't read you all of the bio that he sent along as by way of introduction because it would take up the entire 45 minutes, but I figured I would take out a few things. Carlos comes from a long line of physicians. His grandfather, father, two brothers, several uncles and cousins are all physicians or were physicians. And he got his start at the age of 4, accompanying his dad to his lab at the NIH, where he was doing research on neuronal pathways in giant squid. Carlos is probably the only one in the room or on the Zoom meeting right now who started his research career at the age of 13, anesthetizing and doing tracheostomies in rabbits in order to be able to do neurology research. And I'm sure he's the only one of us who has read Zipes from cell to bedside in 1 week straight. He currently is a cardiologist and electrophysiologist and professor in the Department of Cardiac Sciences and Medicine at the section chief of the cardiology division at the Leiden Cardiovascular Institute of Alberta, Cummings School of Medicine, University of Calgary, and zone head cardiology for the Calgary and Southeastern Alberta region, Alberta Health Sciences. He also holds an adjunct full professor appointment at the Department of Medicine at McMaster University. We're going to have Carlos come back another time to speak with us about his actually groundbreaking work in pulmonary vein ablation for atrial fibrillation. He really set the stage for this entire field of research and clinical endeavors. But he's here today to talk with us about his work with Chagas disease, which, as many of you know, is near and dear to my heart. And I'm sure he'll be sharing with us some of the incredible research that he has done to really move progress in this disease forward. So I will now let Dr. Morillo have the floor, and thanks for the opportunity to introduce you and for coming.
Well, thanks, Rachel. That's a very kind introduction. Most of it I don't deserve, but anyway, it's been a pleasure. And thank you very much for inviting me to your rounds. And I would love to come back to DC sometime. I actually still have some family down there. So these are my main conflicts of interest. You know, I have been involved with Chagas research since the early 90s. And I am part of several advisory boards that have to do with this disease. I chair the DSMB for the Betty trial, which we'll talk a little bit. I'm also the co-PI, and I'm a member of the executive committee of the Parachute heart failure trial that's sponsored by Novartis that we will discuss a little bit. And with Rachel, we've participated in many of these committees and guidelines in trying to make people aware of this important, interesting disease. So I know Rachel has done a huge and incredible job educating you guys on Chagas. So I'm not going to spend too much time on that, but I will, a little Chagas 101 epidemiology, talk a little bit about the work that I've done here on etiologic treatment, a little bit on risk stratification, biomarkers, and disease progression, as well as heart failure management. And of course, you know, as an electrophysiologist, I'm going to talk about ventricular arrhythmias, a bit of provocation and speculation within reason, and what is some future work that we hope to do and the global impact of the disease. A little bit of trivia here, just so that you guys know. I'm sure you all know this gentleman. It's Charles Darwin. There's an ongoing controversy whether Darwin had Chagas disease or not. And as you know, he was at the tip of Argentina and many areas several times. And he wrote in his diary that at night he experienced an attack, because it deserves no less name, of the benchuca, which is the way they call the bug down there in Argentina, a species of Redivius, the great black bug of the pampas. It is most disgusting to feel soft wingless insects about 1 inch long crawling over one's body. Before sucking, they're quite thin, but afterwards they become round and bloated with blood, and in this state, they're easily crushed. So these are the bugs that actually transmit Chagas, Trypanosoma cruzi. And apparently it is said that Darwin died of heart failure, so we don't know if this was related with that. Now, a little 101 on the Trypanosoma life cruzi. Again, this bug that lives embedded in these little huts around Latin America, is the guy that actually transmits the disease. He bites you, and when he gets all bloated, the bug defecates, and that's what actually makes people scratch, and that opens up the skin and lets you, have the bug transmitted over to you. So that's, the way this thing it gets transmitted. Now, that there's an acute phase and a chronic phase, and we will deal with that a little bit more in detail a little bit later. But again, it is something that you can see happening and transmitting the disease. The vector has moved south, and you can find it even in Texas and other places of the United States. And there's, as mentioned, there's a chronic and an acute stage. Um, we do know that there's a geographic distribution of what they call the discrete units of the Trypanosoma cruzi, and we see them across the different areas of South America. Now, TC1 goes up to the states, Texas, New Mexico. TC2 is more concentrated in Brazil and Bolivia. TC3, some areas of Brazil also, and TC5 would be mostly Argentina. So this is important to keep in mind, because sometimes we think that the disease is exactly the same all around the different countries, but this may not necessarily be true. Now, what we know about the disease is, again, there's an acute phase that by and large is asymptomatic. And, it's associated with prolonged fever. It's related with vector transmission. It can frequently be congenital. And that's where, sometimes you may be looking at this. A chronic phase takes 20 to 30 years. We don't know exactly why this happens. We will talk about some of the theories we have about that. And people usually start with some ECG changes. Right bundle branch block with left interfascicular block are usually the hallmark of the disease. I wouldn't say that they're pathognomonic, but they're very frequent. Massive dilated cardiomyopathy, sometimes with megacolon, megaesophagus. Depending on the type of T. cruzi, we don't see much of this. I'm originally from Colombia, so T. cruzi 1 is not that frequently associated with this. More the T. cruzi 2 in Brazil. And again, important to know that reactivation, especially in the setting of co-infections with HIV or other immunodeficiency, when people are being treated for oncologic problems or transplant, they may end up having this. Now, this nice review by Dr. Bakji and others from Brazil was published a couple of years ago in JACC as a nice way to kind of understand what the disease does. So there's first this indeterminate stage where most patients are actually, and patients don't have any signs or symptoms. They have a normal heart, normal ECG, although, we have some data that initially some autonomic disturbances, which is how I got involved initially with Chagas disease, is where it all starts. Now, 70-80% are going to stay in the indeterminate test and basically have positive serology and nothing else. About 20 to 30% takes about 20 years to evolve and get this chronic dilated cardiomyopathy that, has chronic phases with different stages of heart failure, like stage A, in which there's no heart failure, B, where there's some signs and symptoms, mostly of arrhythmia and conduction disorders. Remember, this affects people that are younger, in their early 40s, with a high rate of sudden cardiac death being one of the primary manifestations. So this is how the disease evolves, and this is from the document we put together for the American Heart Association a couple of years ago, in which you see that there's some cardiac rhythm disorders with sinus node dysfunction, AV block, bundle branch block, and ventricular arrhythmias, as well as about a 20% may manifest with atrial fibrillation or stroke being the first manifestation of Chagas cardiomyopathy. They will have a significant segmental wall abnormalities with wall motion abnormalities and dilated cardiomyopathy, aneurysms that are usually apical and inferior, that are the ones that are also the hallmark of the disease, with frequent manifestation of thromboembolisms. Now, you know that this is not a disease that we see only in the endemic countries. That would be, Mexico down to Argentina. Rarely we see this in Uruguay. And you can see that, there's about a significant proportion in the States. And today it's moved around the world just because of migration patterns. Now, it's been said that there's about 300,000 to 400,000 carriers in the US. These are old data. Is this really still the same? I don't know. Maybe we can make that part of the discussion. If 20, 30% of these are going to have cardiomyopathy, well, there's a significant number of these people in the US that either are going to have ventricular arrhythmias or heart failure. So it is the most common parasitic disease in the Americas. It is the leading cause of infectious myocarditis in the world. It has the largest disease burden in chronic and indeterminate patients. And this group, 70%, that we don't know how are they going to evolve or when. And 20 to 30% will have this cardiomyopathy that has actually significant morbidity and mortality and a very fast progression of the disease. And sadly, despite we knowing about Chagas described this disease over 100 years ago, there's only 2 registered compounds. Bisnidazole that was actually approved by the FDA only in 2007 or something like that, and Repurposing that is not approved by the FDA. So it's important to keep that in mind to know how do we treat these patients. And again, a significant burden of congenital Chagas disease. It's important because you may be seeing patients that are pregnant, have babies, and these babies need to be treated if the mother has a positive serology, as this is something that there has been demonstration that, treatment with bisnidazole is highly effective in that population. Now, when I started getting into clinical trials, there was a significant debate about what was the role of the parasite in this population. And this was very contested and very discussed throughout the years. And it was whether, the old paradigm was that this was mostly an autoimmune chronic myocarditis and that the parasite really didn't have much of an issue or a role there. And that for that reason, there's really no indication to get rid of the parasite. Now, new paradigm, which is not that new, maybe over a decade or two, there was more of an inflammatory immune response that was actually triggered by sustained parasite loads. But interestingly enough, this is a low-grade parasite response. Now, not a high concentration of parasites, and we still don't understand how this works, but I'll show you some data around that. And this parasitic persistent was postulated as the main mechanism that was maintaining and sustaining the progression of the cardiomyopathy. And this is why, why not? Giving antiparasitic treatment would be important and useful in that population. Now, I'm going to provide some of the evidence that we've done a little bit, not in order chronologically, but in order, let's say, pathophysiologically. So we did this trial that we were a little bit over the board with the name Stop Chagas. Yeah, well, not happening, but at least it's a good name. Half of what we do in clinical trials is the name. If the name is not catchy, nobody cares. So really what we were trying to do was use an old molecule, the standard of care, which is bisnidazole. And there was some data coming up that was showing that some of these new azoles like posaconazole were effective in these patients. So we did this small randomized trial. And, again, we did screen almost 400 patients, but only 120 ended up being randomized. This was randomized, 30 patients in each arm. We had patients that were receiving only posaconazole, the combination of posaconazole and bisnidazole, only bisnidazole, or 2 placebo. Now, again, this was a trial that we had some difficulties convincing people to participate. My buddies in Brazil actually did not want to participate. Again, some of the challenges we had was that when we designed this trial, the only available bisnidazole was something that, because initially bisnidazole was produced by Roche decided to drop it and give it to the Brazilians. And there was a company in Brazil producing bisnidazole, but they only produce doses that, medication that cannot be fractionated. So we cannot actually give the 5 to 8 milligrams dose, but just a single dose. And, that was an issue for the Brazilians. They thought that that was not ethical. And they also thought that giving placebo was not ethical. Now, there was equipoise at this point in time because no one had demonstrated that, giving this for a short period of time either was harmful or benefited the patients regarding the progression. All of these were patients in the indeterminate stage. So there you go. Anyways, this was the trial that we designed. It was the first trial that was actually also looking at combination therapy. And we had this population that was relatively young. Mean age was in the early 40s to 50s. And again, not very obese patients like you see in Latin America and these countries that participated in this. Was also one of the first trials to use a non-endemic country where a lot of people have migrated with Chagas disease, mostly from Bolivia. So that would be T cruci 2, maybe 5, to Spain. So this was important that we had a significant population there in that study, mostly all with normal LV function and with no evidence of any cardiac disease. Now, importantly, what we looked was, how did we look at the outcomes? The outcome is something that we developed throughout the years, because when we first applied for grants for the, initially benefit that I'll show you in a minute, and then this Stop Chagas, it was a trial done with Merck that owned posaconazole, was, okay, how do we demonstrate that this thing is working? And most of the people will tell you, well, you don't know if this is working or not. So maybe you should do something to demonstrate that you're doing something against the parasite. So we got into real-time PCR, which basically detects DNA of the parasite and apparently tells you that the parasite is circulating. So yeah, it is a good marker. So what you see here in the blue line, this was the posaconazole alone. So after the 60 days of treatment, which was, the usual treatment, you see a huge drop in the percent of a negative. So these people kind of went back to having lots of parasites. And on the contrary, the people that were on posaconazole combined with bisnidazole or bisnidazole alone maintained, negative PCRs, almost 90% for over a year. So really, the treatment failure was very low. Only with placebo, it's about very high. So again, very interesting. We looked at the intention to treat and the per protocol analysis. So the other thing that was interesting here is that you can see that this starts working really early. By 30 days, just 4 weeks, we already started to see some treatment effect. Yeah, this was 400 milligrams, 200 milligrams BID. So a little bit higher than the usual dose that would be 300 milligrams. But still, it showed that this was very effective treatment. Now, before that, it took us some time, almost a decade, to do this trial. It was the benefit trial. And you know that there was a significant discussion whether I did show you that, we think that the parasite is important, and maybe trying to eradicate the parasite will have a significant effect on this important outcome of progression to cardiomyopathy. And that's where we came up with the benefit trial. The benefit trial was a massive trial, at least from the standards of Chagas. We enrolled almost 3,000 patients in 50 sites in 5 countries in Latin America. Now, this was a randomized double-blind trial in which patients with chronic Chagas cardiomyopathy, but that were not too advanced, mostly in New York Heart Class 1 and 2, were randomized to bisnidazole 300 milligrams a day or placebo, and were followed for about almost 6 years, with a primary outcome that was a hard outcome kind of composite of death, and you can read it there: resuscitated cardiac arrest, VT, etc., which we thought were all the important outcomes in Chagas disease. Now, the trial, again, younger patients, about an age of 55. Half were male, so this was well distributed from the sex perspective. Most with abnormalities in their ECGs, primarily, right bundle branch block and fascicular block, with atrial fibrillation about 8% of the population, with complex ventricular arrhythmias about 15%, a low proportion of patients that had either heart failure, about 10%, or resuscitated cardiac arrest, less than 1%. And as said, most of the patients, about 90%, were either in class 1 or class 2. Class 4 was an exclusion criteria for the trial. Very few proportion of patients with defibrillators, mostly because, again, these were probably patients with preserved LV function. And that's something we can leave for the discussion also, with other characteristics here. Now, remember that this was published in 2015, so it took us about 10 years to recruit these patients. We started back in the early 2000s. So not a lot of it, about 30% were on diuretics, very few people on spironolactone, ACE or ARBs, only 50%, digoxin, 11%, almost 20% on amiodarone. And because, as you may or may not know, Chagas disease usually is associated with bradycardia and heart blocks, so people are relatively reluctant to use beta blockers. So only 30% were on beta blockers. So really probably not optimal medical therapy. So the first thing that we observed was we wanted to look at the PCR conversion rate. And we did this at baseline after 2 years and 5 years. And this is the overall population. See that there's a trend to this dropping. Now, we did see that in Brazil initially, there was a very significant effect. And at 2 years, this was dropping. And by 5 years, this had dropped significantly. So there was no sustained effect on reducing the parasite load. So red flags, should we do something different? But the behavior was different in Bolivia and in Colombia. So why was this? Why didn't we see any effect here and very moderate here? And why did we see such a huge effect in Brazil, which led to a lot of discussions and conversations about what was going on? Now, when we looked at the overall sample, and again, you can see this here in Brazil, there was an interaction, interaction that was positive when we looked at that based on country on the PCR response. But when we look at the other outcomes, there is absolutely no difference in outcomes at almost 7 years of follow-up. So there's a very long follow-up here, placebo versus bisnidazole. And you can see again here, when you look at the primary outcome, there's no difference among the countries. Didn't matter if you had a positive or negative PCR, what age you were. But the only interaction that was actually interesting was the use of amiodarone. So patients that were on amiodarone actually appeared to have a significant reduction in these outcomes. Was this only because the amiodarone was having an effect on cardiac arrhythmias, or there's other issues? Now, we do know today that amiodarone actually has an anti-T cruci effect. So it has an anti-parasitic effect. So that's something that we need, and we're trying to explore a little bit more in detail in other studies. Now, this led to a lot of dissent. Running clinical trials is like politics, and especially, when you're with Brazilians and people from other areas of Latin America. So Brazilians own the disease because it was Chagas who discovered the disease. And you can see here that seemed to be a trend in that this was working. But again, if you look at the confidence interval, this crosses the line of identity. So really, it was still consistent, although there was a signal there. We couldn't say that this was actually working in Brazil. And why would it work in Brazil and not in other countries? That's something that we're still debating. Now, most of the patients, really, it's a high proportion of patients. The main primary outcome was, death, followed by worsening of heart failure. So really, these people die, and most of the deaths are either of heart failure, or actually are related with sudden cardiac death, and that's what we tried to evaluate there. But interestingly, when we looked at any hospitalization, it looked like there was a marginally significant P here when we gave bisnidazole. So food for thought. Although again, interpretation, if you are a strict methodologist, well, the trial overall was negative, or maybe let's be a little bit more cautious and say it was a neutral trial. But there were some issues there that we could still look into. And some of the things that we looked into was this parasite load. And you can see here that, the patients in Brazil had very low parasite load, lots of outcomes. Argentina, Colombia had high parasite load. So maybe why didn't this work? Because you saw these curves on PCR, didn't make any change in Colombia, lots of change in Brazil. So maybe people that had low parasite load were the responders, like, CRT super responders, and those that had very high parasite loads, maybe that need, we only give one treatment for a disease that's been around for 20 years. Maybe we missed the mark. Maybe we should have done something like what they do in TB. You give treatments for years until you kind of really eradicate the disease. So food for thought for further trials. Now, there's very interesting study in which, Rachel has collaborated with us and with a friend of us, Dr. Cheverria, who's in Bucaramanga in Colombia, where I started doing my studies in Chagas and still have a very close relationship with that group. But this is very interesting, looking at a composite outcome of death, cardiac transplant, and LVADs. Now, intuitively, you would say, oh, yeah, sure, this is the patients that had low parasitemia do better. No, actually, the patients that have low parasitemia are the ones that did worse. Now, when you don't have parasites at all, it's when your LV function is not, there's the proportion of patients with reduced LV function. So those that had low parasitemia, 80% had that. So this seems counterintuitive. How do we explain this? Now, this is hard to explain, but the hypothesis around this may be that, okay, maybe what's happening is that, yes, this is this low grade, persistent parasite that leads to all this other inflammatory response that is the one that is kind of making these patients have worse outcomes, such as dying and going to a cardiac transplant or getting an LVAD. So very interesting data that we've recently collected in this group there in Colombia in collaboration with Rachel and many others. Now, how do we treat these people? Should we just use a fixed dose? Should we use a higher dose? This is still under dispute. And there's not a lot of trials. The Bendita trial that has not been published yet, but will be published in the next few weeks in Lancet Infectious Diseases. And I wrote the editorial for this. Will be coming out soon. They basically looked at different dosing and different timing, coming to the conclusion that maybe just 2 weeks of 300 milligrams of bisnidazole is enough to pretty much eradicate the parasite in a population with indeterminate stage. Now, can we risk stratify these patients? Because we can't do every single test and treat everyone with Chagas. We wouldn't have the money, the resources, and you in DC, probably there's a big Latino community there. Does everyone that comes from Latin America have Chagas? Well, probably not. But there are some countries in which you definitely need to concentrate, like Brazil, Argentina, Colombia, and some of the countries in Central America, Guatemala, and Nicaragua. So this is a sub-study from the BENEFIT trial in which we looked at what was the effect of trypanocytal treatment on some of the echocardiographic parameters of cardiomyopathy and wall motion score index. And basically, just to show you that when you have an increased wall motion index, just showing you that there's probably more scar around there, these people do really bad. Primary outcome of the BENEFIT trial that was a combination of death, et cetera. You already saw that, but it's primarily driven by death and heart failure. By 7 years, 60% of these people are either dead or have had recurrent heart failure. So simple ways of identifying this population. And you can see here mortality, almost 50% are dead by 7 years. And again, this may be related with the treatment we're giving them, or simply that these people have a high rate of death. Now, we've developed the benefit score, and again, sometimes trying to get some of this stuff published is a nightmare. We've gone through a few journals on this, but hopefully now it's going to be published in the near future. Now, we looked at age and different issues. We wanted to look at all-cause mortality, and also you can see that segmental contractility, very simple markers that you can find either from the clinical history or an echocardiogram. We get some point scores, and also for the primary outcome, people that are going to develop either of the outcomes based on perimeter ventricular complexes, et cetera. You can read those there. We find that these people using this risk score, and why is it important to use this risk score? Well, because, if you have a low risk score, around 0 to 3, by 6 years, your mortality is going to be really low, way less than 10%. Less than 5%, as a matter of fact. So maybe this population doesn't need to be monitored as strictly. Maybe they only need to be optimally medically managed. But these populations here in the intermediate and of course the high risk, these are populations that are either going to die from heart failure or from sudden cardiac death. So this is a population that we need to focus and we need to address. And we've done some, everybody does AI now and machine learning, and we've done some machine learning, and we've seen that, these decision trees are actually pretty good. and we can use this more on a population basis to try to identify this population. Now, we've spoken about all this other low-grade inflammation in cytokine profiling, and this is another sub-study from the benefit trial that we published a few years ago, in which we actually show that, IL-4 and 2 are important, and they also depend on the type of T. cruzi. We can kind of typify which ones are the ones, and combining the genotype and of the circulating T. cruzi with some of these characteristics, we're able to be a little bit more precise. So moving towards what we all call precision medicine, even in Chagas disease, to try to manage these patients. Now, with our colleague, Dr. Echeverria in Colombia, we've done some very nice studies looking at biomarkers according to the severity of the disease. And we've looked at NT-proBNP and a number of others that you can see here, galactin-3, high sensitivity troponin, etc. And there's some very good correlation with the progression of the disease. And several other trials have been looking at this. So this is something where we are concentration significant amount of resources. We've looked at matrix metalloproteinases in the past, and several other genotypes that we looked in these populations. Now, this is actually a very nice study, also from my good friend, Dr. Cheria, that we collaborated with. And this has been recently published, and they've looked at this marker and echo with speckle tracking and looking in brain natriuretic peptide. And actually, interestingly enough, even in patients in the indeterminate stage, some of these markers can already identify with you, if you combine it with proBNP, with a very high sensitivity and specificity, which are the patients that are going to be progressing. So maybe aggressive parasite treatment and maybe some early heart failure treatment in these patients would be indicated in these conditions. Now, heart failure has definitely not been very well studied in Chagas. We've all felt that, yeah, well, it's a dilated cardiomyopathy, treated as like any other cardiomyopathy. Very, very little data, very few randomized trials, mostly non-randomized, looking at, ACE inhibitors, pretty much none looking at ARBs and at other interventions, some sub-analysis from the SHIFT trial looking at ivabradine, but again, not a lot of good data on that. This is some of the data from that we haven't published yet from Benefit, looking at how the usage of some of these treatments varies so significantly among countries. And you can see here in Brazil, for example, ACE inhibitors and ARBs, almost 67%, very low proportion in Argentina and Bolivia, higher proportion in Colombia. Is this only access to care, or what is going on here? Very low proportion of beta blockers, again, in Argentina and Bolivia, and high proportion of amiodarone, almost 30% in Brazil, and very low in Colombia and El Salvador. So these are issues that we're trying to address, looking also by ejection fraction, seeing some interactions here among the different countries. So we're trying to understand why are these differences so important, and how does this affect the progression of the disease. So now we're doing with Dr. Renato Lopez from Duke University and other people in Brazil, myself, Luisa Echeverria also, the Parachute trial. The Parachute trial is the prevention and reduction of adverse outcomes in Chagas heart failure. And this is sponsored by Novartis. And this, again, is this win-win ratio. It's a hierarchically ordered kind of a composite. And we've started the trial. It's a trial of sacubitril against enalapril. And you see the design there. And we're aiming to enroll about 1,200 patients. The study is already started in Colombia, Brazil, Argentina, and Mexico. We're hoping to get some centers also in Guatemala, Honduras, and El Salvador. And this is our last recruitment data. We already have about 60 patients randomized in the trial, screened about 115. So we're doing okay there. And this is a very important trial. You would have never seen industry fund a trial dedicated for Chagas disease if we hadn't done Stop Chagas Benefit. So I think that there's been some conscious and is brought up to the table, and industry is significantly involved now with these new trials. And I think this trial is going to provide significant responses and answers because, as you know, sudden cardiac death, arrhythmias, we know that sacubitril valsartan has a marked reduction in all those markers, so we'll see how that goes. And this brings me to sudden cardiac death and Chagas disease, that again, there's this sort of a Meyerberg plot, but looking only at Chagas disease. And you can see that there's a very significant proportion of patients that are going to have Chagas sudden cardiac death that we are really not looking at, from the population basis. So we hope to look into that. That's something that we did a long time ago when I was still back in Colombia. In 2000, I had moved back to Canada, but I did this with a good friend that used to be at Georgetown University. I think he's at the VA there in Washington. I haven't seen him for a while. This is Dr. Michael France, who is the guy that developed the monophasic action potential catheter. So these are unique recordings of monophasic action potential recordings in patients with Chagas cardiomyopathy before the induction of ventricular tachycardia. So this is actually something that had never been shown before, and we've done this and looking at the mechanisms of sudden cardiac death in this population. Now we know that we can actually quantify the amount of fibrosis and scar, and that this correlates quite well with the prognosis of Chagas cardiomyopathy. And then looking at the burden also, and it varies depending on the study, anywhere between less than 12.3 grams or more than 12.3 grams. You can see that the outcomes and correlation with death, which by and large is going to be either heart failure or sudden cardiac death, is quite significant and high. So we've progressed in that sense. And, other studies that we've been doing, looking at PET scan, looking at inflammation and autonomic dysfunction correlation with MIBG, we can see that these patients have significant alterations, and eventually targeting some of these very specifically, we can reduce sudden cardiac death in this population. Very nice review of one of my previous trainees that's now in New York City. And they've published this a couple of weeks ago. And I recommend this for anyone who's interested. Looking at the myocardial substrate, that we've looked at these different scars, inferior posterior wall, apical aneurysms, bringing these VTs, and some trials and randomized trials showing the benefits of endoepicardial ablation, some cardiac denervation. And one of my former fellows actually did the first studies of renal denervation in addition to reduce shock. So we know that very nicely, these studies, we can do some high density maps, correlate them very nicely with scar burden and scar location in Chagas, and target these areas and provide this sort of algorithm. So patients with chronic Chagas cardiomyopathy that are refractory to conventional antiarrhythmics, including antiarrhythmic drugs. There's data from a randomized trial in Brazil that has showed that endoepicardial mapping should be the first approach, and it's superior to only endocardial or only epicardial mapping. So if there's no recurrence of VT, well, you stop there. If there's recurrence of VT, then you do cardiac sympathetic denervation, and this can be done by many thoracoscopy, and there's some nice data from my friends in Colombia, in Bogota, Dr. Sanz, that has done this with the people at UCLA. And then bilateral renal sympathetic denervation, again, my former fellow, Dr. Luciana Armaganijan, has provided this. So we're now developing some randomized clinical trials in which we're going to be doing a stepwise approach in this. So definitely we've changed the course of Chagas. Didn't have any clinical trials a decade ago. Now we have several trials looking at this. And you can see here the combined endoepicardial from the group by Dr. Scanavaca in the INCOR in Sao Paulo, randomized trial, small one, but quite powerful. Looking at cervical thoracic sympathectomy, Dr. Sainz in Colombia, and other people, and Dr. Magañajan with renal denervation. So we're combining all this into a stepwise kind of randomized clinical trial that we're hoping to launch within the next few months or so. A few words about transplant. It does work. This is a 10-year follow-up of about 100 patients or so from my good friend in Bucaramanga in Colombia, where I also still am part of that group. And you can see very good outcomes in these patients that are followed with a specific protocol. As you know, immunosuppression, some people use benznidazole routinely. We haven't done that, and there's only been 1 or 2 patients that have had reactivation of Chagas, and we just target and treat them appropriately. So no need to carpet treat all these patients per se. Now, repurposing of drugs has been where we've focused mostly with azoles, and you can see here that there's been a lot of molecules that have been tried. E1221 rosiconazole, published in Lancet recently, no benefit by itself. It does do well when it's combined with benznidazole. So again, seems like the old structure still seems to be the standard of care. And there's a lot of stuff going on, but some that I would make your attention, like amiodarone, not only because of its antiarrhythmic, but you can see here the crucipain activity. So it does have significant activity against T. cruci. Colchicine here. So should we be doing trials in which we also associate colchicine? And that's something that we're moving forward and doing this. And we've done some GWAS studies and some other identification and repurposing, and that's where we are at this point in time. Now, there's a bunch of clinical trials that are assessing new regimens of the current trypanosome drugs. We started with Stop Chagas. Now there's the Bendita, Multibens, the Betty trial, which is actually run from Texas, and the Teseo trial. So lots of trials that are not only being done in endemic areas, but like the Betty trial are being conducted mostly from North America. So this is something that is important to see, that we have changed the scope and the focus of Chagas. And this is a little summary of where we are and where we're going with this new treatment. Now, where's the research landscape in 2021? And again, screening and other opportunities that we have. We've been looking at different areas, and there's different consortiums around the world that are very globally connected in doing this. And you know, different substances, and we're already working on benefit 2. That is going to be actually a factorial design in which we're not only going to use prolonged and repeated doses of antiparasitics, but we are going to use colchicine as a background treatment in this population. So this has grown a lot. You know, I looked at this last night. There's over 50 randomized clinical trials now in that are in clinicaltrials.gov. So I think this has changed a lot. We've made a lot of advances in international.
Did Dr. Morillo freeze for everybody? Did for me.
Yes, Gabby, he froze for me too.
I don't know, Rachel, if you have his cell or some way to stop his video real quick, see if that helps. So I think we lost him here for a moment. We'll see if he's able to log back on. So we're trying to reach him and see if he can come back on. I'm not sure what happened with his internet. We'll give it another minute or two. We're doing okay with time. I see him coming back on. You're muted, Carlos. We see you.
Yeah, not sure what happened there. Sorry about that. A little
Yeah, no
glitch there.
problem. Thanks so much for logging back on.
But I guess we'll open the discussion because something happened to my slides here. I'm not sure what happened. Anyways.
That was great. Thanks for the overview. We'll open up the floor for questions. I just wanted to ask one quick thing. One of the things you mentioned on your disclosure was your work with orphan drugs. And I just wanted to get sort of your perspective when you're working with this kind of disease. What are issues as far as pharma goes and the FDA in dealing with these sort of, smaller populations, at least in the United States? And what have you guys run into and how do you deal with that?
Yeah, that's a great question. It's been challenging because, as I told you, for example, Repurposing has not been approved by the FDA because, the FDA always needs data in the US to be able to approve most of these drugs. So the way we've been getting around, at least that's what we were able to do with bisnitasol, is that we put together all the clinical trials that we had, and we put kind of a dossier on the information, and spoke with the FDA and told them that there's no other drugs available. There's no development of new drugs until more recently with all the azoles that unfortunately have all been demonstrated to be not very effective in this case. So what we've tried to do is use, data from all the trials and bring that data in a transparent way to the FDA, let them review it and see if they, after reviewing the data from the trials that they get full access to, have accepted this, at least for bisnitasol. We haven't been that lucky for nifurtimox, but that's been, one of the issues.
Oh, thanks. The floor is open to Steve. I see Epstein. I see your hand up.
Carlos, thanks very much. That was really fascinating and really comprehensive review. I was struck by a number of things. One is Chagas disease has been described as a chronic inflammatory condition. Two, you showed this very interesting slide, which was counterintuitive, that the lower the parasite, I guess it's circulating DNA levels, the worse the disease.
Yeah.
Now, that to me is a very powerful, generates very powerfully a hypothesis that if you have a very potent inflammatory response targeting the parasite and reducing circulating loads, that may be an indication that the inflammation, which reduces circulating parasite loads, may be an important etiologic mechanism responsible for chronic myocarditis and deterioration of myocardial function. And of course, everybody is, what else does Epstein have to say? We're very, very interested in inflammation in myocarditis. We're just applying to the FDA for a protocol on the use of a anti-inflammatory strategy that we have to treat myocarditis. Is there any, there's an enormous number of trials, as you indicated, on anti-parasitic drug programs, but they haven't been, at least as you've described them to us, they haven't been very exciting in terms of outcome. Have there been any serious attempts to look at long-term anti-inflammatory therapies to improve outcomes in these patients?
Yeah, that's a great question. Those are the 3 or 4 slides that I missed there, and where I was going to deal with that. But again, that's why there's no data really on large scale trials. Some very initial data with some drugs. Now in Chagas, you need to be aware that we need to find something that is easily approachable and is cheap. So that's why we're going to use colchicine in a 2x2 factorial design with some antiparasitic drugs also. So this is what we call benefit 2. And we're already getting some funding for that. But, I sometimes feel, well, what about, if we use drugs like, those using Cantos or other of these clinical trials, would the impact be greater? But let's start with demonstrating, I think you made the right observation. It's fascinating to see that those that had low parasites basically had the worst outcomes. And this has to be really linked with this low-grade chronic inflammatory disease, that if we're able to tackle that, we are probably going to change the course of the disease. So that's what we're doing and proposing for benefit 2.
Yeah, I mean, colchicine is an interesting drug, and it is anti-inflammatory. I'm not sure it's the most potent drug that I would choose to use, but that's going to be an interesting study to follow up on. Thank you very much.
Oh, you have other suggestions, and you can put us in touch with the people that make those drugs. We can talk about this.
Yeah, well, I'd love to get in touch with you because we're very heavily involved in that.
There you go. Well, now you know where to find me.
Okay.
Other questions?
Carlos, this is Rachel. Thank you so much. That was really such a fantastic and overview of the science and the trials. I wanted to see if I could have you help us with the clinical scenario that comes up when you have a patient who has a mildly depressed EF, or one of your patients, say from the Benefit Echo sub-study, who has a wall motion index that's greater than 1 but less than 1.5. So probably with a relatively preserved EF, and how you would deal with their significantly higher risk for ventricular arrhythmia. And so what guidance you would give us in terms of the evaluation of those patients.
Yeah, it's a great question. I think that one of the things that I would do definitely in that population is a CMR. And if I do find a significant burden of scar, I would have a low threshold to probably put a defibrillator in that population, or combine therapy with amiodarone. I think that there's some growing data that we have seen in that population that they're going to be at a high risk of sudden cardiac death. And if you have the ability, and in North America, I would say it's not that difficult to get a CMR in this population. And if you actually, and again, unfortunately, those were some of the slides that I ended up skipping, where I was going to provide a little bit of some guidance on what to do in these cases. But that's what I would do in that case. I don't know if you have any other suggestions, or how do you guys are managing these?
That's certainly my plug. And then I guess the other question is when or if you think there might be a role for EP studies in those patients.
Yeah, it's always been I'm an EP guy. But we've gone from, when I started EP a long time ago with George Klein, we were doing EP studies on every single thing that moved. And now we've moved away from that. But I think that in a, scar-related VT, I think there is a role. An EP study is a relatively non-invasive, safe procedure. So if there's still some question, and let's say you get this scar burden that is kind of in the gray zone. Some people are talking about more than 12%, more than 20%. Let's say you get 10 or 15%. So what do? I would support taking that guy to the EP lab. If you induce sustained VT, sure, go for it. Yeah, either. And then again, this is another topic where we've done some other studies in other areas like ischemic cardiomyopathy, whether, okay, is this population first-line therapy for VT ablation or first-line therapy for ICD? That would be another discussion to have. Or modulation of the autonomic nervous system, as I briefly showed you, is actually quite powerful in Chagas. So we are promoting, and again, I don't see a lot of Chagas here in Calgary, but when I go down to Brazil and Colombia and the centers that I collaborate with, we are doing PET scan. We are looking at the MIBG proportion. We are looking at all these together, and together we put a picture and we make a decision. I think that's the way to go in this population.
Thank you.
So Carlos, just a question for you about the imaging, right? I mean, you sort of brought that up a little bit there about all the imaging techniques that are available and sort of how you're looking at it. And you talked a lot about MRI, and as an MRI person, that sounds great to me. But where, so, if you're thinking about risk stratifying these patients based on what you know so far, do you think we're heading towards, or do we have like a way to put all of this together? Like, for hypertroph, we think of, if you have these and these factors together, then that puts the patient at higher risk. Is it echo strain plus something that you see on PET plus MRI? Or is there one thing that's the most important? For example, if scar is really the determinant of what's going to happen to these patients, then sure, MRI is a great way to look at scar, but is there more to it than that, I suppose? Where do we stand?
That's a great question. That's a great question. I think that, we're doing a bunch of other studies. I did show you briefly some AI and machine learning that we're doing. Now we're actually applying AI and machine learning to the ECG. And as you know, and we're working with Peter Friedman and the people from Mayo that have already looked at how you can predict, LV function and markers like this from the ECG. And we're actually working on a project in which, based on AI and machine learning from analysis of the ECG, we can actually predict the burden of scar. So it's going to become a combination of things. And maybe what's going to come down is that maybe one of these imaging tests is the one that has the greatest, area under the curve. And if you combine that with some ECG markers and some clinical markers that I briefly showed you from the benefit score that can be easily introduced there, we will be able to have this risk score in which you say, okay, this guy has a 10% risk of sudden cardiac death within the next 5 years. So the next step would be to do a randomized trial using that marker and to validate this. And we're hoping to get there in the next few years, but that's where we're moving.
Great. Any other questions? Well, thanks so much, Carlos. That was really a tour de force of so much work over many years to really shed so much light on this disease. And we look forward to updates as some of the other work that you've sort of mentioned is in progress comes out. And we hope to see you in DC.
Well, thank you very much for the invitation. And you take care, and I'll see you sometime soon.
All right, take care. Bye-bye.
Bye now.